And let's jump in. The key things for us to.
Sorry,
Oops.
this is Renew. I just wanted to let you know that I'm on as well. I just can't turn my camera on right now due to my internet.
Oh, okay. Well, Renu, first of all, thank you for that wonderful presentation yesterday that set the tone for this discussion. And just jump in anytime since I won't be able to see you, but we definitely want you to participate in this.
Thanks,
Um,
Risa.
and I think the key things for us to remember and what Neil said to us, and I'm going to use first names. I haven't met some of you. I'm not being presumptuous. It's just Laviso Mori is a lot to say, so I don't want to put you through that. And so what Neil said was, let's first start with what other additional concepts do we want to get out on the table as we think about what PCORI might do vis-a-vis infrastructure over the next 5 years. So jump in. Other concepts that we need to get out there.
Yeah, I'm happy to start, and Renu, again, echo the wonderful set of remarks that you made yesterday. Thank you so much for that. Recently at Faster Cures, we've been involved in identifying lessons learned coming out of COVID-19 in terms of silver linings, if you will, that's accelerated by medical research that we want to keep going into the future. One of those topics is infrastructure. Particularly the clinical trial networks that were stood up to support both the therapeutic and the vaccine clinical trials. NIH did a fantastic inventory of their capacity for clinical trial and then deployed that capacity for these COVID trials. And what we want to ensure is that we don't go back to status quo where the trial networks that were established and pulled together dissipate and go back into whatever previous areas of focus where they had, which I think is quite important. But I think the broader question is, how do we leverage the infrastructure that's been created for the response to COVID to be deployed for other disease conditions or public health crises as they rise to the top? I do think that there's some cross sectoral issues that we need to identify and deal with: contracting, indemnification, central IRB issues and challenges, the regulatory approach, providing effective communications. But just wanted to put that on the table as we're thinking about the future in a blue sky mode. How do we build upon what we pulled together and not lose that, including even the partnerships that were established? Active as an example, the public-private partnership that Dr. Francis Collins stood up, RADx as yet another example. Transcelerate brought their resources to bear, as did other biotechs and biopharma. And again, those were not going to continue without some kind of infrastructure created around them, thinking about the resourcing and staffing and deployment for other conditions. So just wanted to put that on the table. I know you articulated some of this, Renu, yesterday, but just wanted to raise it again.
Yeah, great point, Esther. And I just wonder if, as you have talked about this in Faster Cures, whether there are any particular conditions or situations that you're identifying as perhaps the right conditions or situations to act as an accelerant for this next phase of solidifying those networks.
Yeah, I mean, I do think that there's going to have to be a prioritization process to identify what are the emerging public health threats and how can we best deploy. What we saw with COVID-19 was extreme focus because we're trying to get past this one virus, one pathogen. But there are some conversations about, can it be redeployed for Alzheimer's disease, maybe rare disease conditions in terms of leveraging master protocols and the networks in order to conduct those trials where there are very few patients. But there's also a lot of interest in establishing more community-based clinical trial sites that can bring more people into the medical research ecosystem. And that might be for broader disease conditions, not just things like rare diseases. But that will have to be a public-private process that we go through and prioritize what those disease conditions could be, maybe identifying where we're seeing rising healthcare costs combined with increased prevalence, morbidity, and mortality, and then low innovation activity as potentials for identifying those priority areas.
Excellent. Okay. Other things that are concepts we want to add to the discussion from yesterday. Oh no, I just got something that says our breakout rooms are going to close in 53 seconds.
Yes.
I think
they're trying to fix that in the background.
Okay, well, if we all disappear in 41 seconds, please don't hang up. We will be put back into breakout.
Yeah,
okay?
We're experiencing technical difficulties, and when you get booted out, you will be placed back in your original rooms. We apologize. Okay. We're not sure.
Okay. All right. Can anyone give us 25 seconds of an additional concept that we need to get out there?
I think I'll just tee up for your thoughts before we leave and come back. The role of communication and dissemination as an infrastructure function.
Excellent. Okay. All right. Well, we may be jettisoned in 2 seconds. If so, we will start.
It wouldn't be a virtual meeting without a Zoom hiccup, right?
Well, I'm delighted we're going to add translation dissemination to the conversation. I have a lot of thoughts about that, and I have a few other thoughts about data. So I want maybe for conversation organization, you want to sort of keep them and go stay on one topic and then move to the next. I don't want to blur things too much. So.
Well, why don't you expand on that now, Austin, as a concept that we want to make sure gets in there in association with infrastructure.
Okay. Well, translation dissemination has a bunch of different components and meanings to different people. There's obviously translation to the beds, from research to the bedside. I do a lot of work more in the dissemination space, trying to reach broader audiences with the work of the research community. I think that is incredibly essential, especially when the research is intended to be policy relevant. And policy, I mean broadly, it could be federal, state, local, but also to private organizations and health systems. They all have policies and practices. I give talks about this all the time, and I tell researchers, if you are not finding a way to communicate what you do to the audience that it's intended for, which is not just other researchers, but those other policy communities, there's no reason why you should be funded. That's how stark I am about it. I'm like, we should not be paying for research that just goes in a journal. We need that research. We need the journal. We need the rigor. We need the peer review. We need the foundation, but we have to do more. We have to bring it up and out. And I could talk for 2 hours about it. So anyway, that's.
Yeah, what I'm hearing you say is that as we think about infrastructure, we need to be sure that this is inextricably tied to it so that you don't think of one without the other. And I would just offer as by way of example, what we've learned when the communication wasn't tied to infrastructure and dissemination with COVID-19. We just didn't have that tightly and accurately linked. So there's a big example right there. Anything else on additional concepts before we move on to the next question?
I would like to raise the notion of thinking of non-healthcare provider community-based organizations as a part of the broader health infrastructure, and assessing the level of investment and support that they need in order to bring and help to bring a strong consumer voice to the table, whether we're doing research or thinking about system redesign. I was really attracted to some of the conversation yesterday about thinking about patient strength and patient expectation, not just patient need. And it really reminded me of the fact that, you know, one of the lessons I think through COVID-19 was a lot of community-based organizations were the go-to for a lot of people in their communities. Just, you know, a lot of these groups are not even, you know, service organizations, they're advocacy organizations, and still had to kind of rewire their organization because they were being inundated by calls and questions from community members who trusted them to give them good information about what COVID-19 is, as well as we're looking for information about how they can get help, whether that be nutrition assistance or housing assistance or unemployment assistance. So I think thinking about the role of community-based organizations and the ways in which they need to be a resource as a part of health infrastructure is an important topic from where I sit.
And Emily, let me first just welcome Lee. Lee, we're on sort of our first question of whether there are any additional concepts we want to get out there. And Emily, if I could just ask you whether, as you think about that, are there the ways in which we need to expand the infrastructure and how we define it? Are there any other organizations or categories of organizations that you would put in there with, you know, community-based organizations?
I mean, I guess I view community-based organizations pretty broadly, you know, to include any, you know, local, largely local, but also state-based organization that has done a lot of work or is positioned to do a lot of work, you know, to engage directly with the community, whether they're doing social services work or doing, you know, community organizing work, essentially. I think it's a highly unresourced and, you know, as you know, largely reliant on private foundations to try to resource the work that they do. And I think there's a lot more that could be done through government to give them more of a platform to engage people in health.
Great.
So, Risa, I was just listening this morning as we were talking at the agency about some of the provisions of the Recovery Act, and community-based is in there with a lack of clarity. So it may be even more important right now to see how they can be most effectively utilized for, like, we're trying to figure out what we would do, what do we resource? What is it for the money?
And this might be a good lead into our next question, which is, what are the potential disruptors and opportunities on the horizon related to infrastructure? Esther, you look like you want to jump in.
Well, I was going to just comment on the data sharing. Maybe Austin has even more refined thoughts there. But the ability to be able to link data, I think, offers us the opportunity to leverage the networks that we established to ask really good questions. Some come to mind. DataVant, during the course of COVID-19, put together a research database that linked many different kinds of data sources, from lab data to EHR data to mobility data and other kinds of data in a de-identified way that researchers could apply for and get access to run and analyze a variety of research questions. And NCATS did something similar through NC3. But the ability for us to be able to aggregate data, I think, was really a disruptive moment that forced maybe potential competitors to put aside their interests and come together to figure it out and find a way, including even the CTSAs, for example, that are funded through NCATS, that for many, many years, they were trying to find ways to share information, create harmonization of data standards, and they finally got it done and put it over the finish line because the pandemic forced them to do so. So that has the potential to be disruptive if we can find a way to continue those practices going forward and not get caught up with, legal contracts and small print terms and conditions.
Sorry, I don't have the questions in front of me. Was this and I didn't quite catch, was this disruptors or barriers, or just disruptors? Disruptors is usually positive.
Yeah, we're focusing on the positive, the potential disruptors and opportunities related to infrastructure.
Yeah, I think I'd only have obvious things to say. I mean, the COVID inspired boom in telemedicine is, is a potential disruptor, to the extent it continues. It does, it's infrastructure in multiple ways. It's a new-ish care delivery method that, can lead to expansion and access, obviously. But then there's the data gathering aspect of it. And questions about interpretation. What does a televisit with different specialties, mean, versus an office visit? What data can be gathered? How do you integrate maybe data that is collected from the individual, in their home with wearables and so forth? So it's, I think there's a lot of, there's kind of a new frontier there.
Yeah, I want to just augment that a bit, because I was thinking the same thing. It's part of it is the data itself. We have not really been in a position to enter people's homes virtually and bring back all that might entail. We don't know how to use that data. We haven't fully studied how to interpret it. What if you see someone sitting with several layers of clothing on inside? Does that mean their heat's been turned off? Do you probe on different questions? It seems to me that this could be hugely disruptive as we try to think about how to use that information. What else?
And this is disruption of infrastructure per se.
Well, disruptions that could affect positively, I guess, the way we think about infrastructure. Go ahead, Esther.
I mean, again, this is maybe a little bit, and I don't mean to monopolize, too focused on clinical trials. It's ex-US, but learning from the recovery trials in the UK and how they leverage their infrastructure in a really nimble way to answer questions and generate evidence very quickly against the things that the community society needed. I think that was one hugely beneficial, helpful, disruptive, all of those very good things. What can we learn from that model in a US context would be helpful for us to investigate and think about. There's some obvious things that allow recovery to do what it did, but what can we learn from that in our context to help be much more nimble as well?
Epic created an interesting data set around COVID in all their hospitals and started to stand up databases that could be gleaned. NHSN was expanded tremendously at the CDC, the National Healthcare Surveillance Network. So I think there are some unique networks and data sets that were put together during the pandemic, that the question is, how could they be used post-pandemic?
Yeah, just building on that, one of the things that Karen DeSalvo said a couple of times yesterday is that we should be thinking about health and healthcare, public health, and how it's going to help us create better systems and better infrastructure. And, building on the COVID example, one of the things that we started looking at was how far afield do people move, and using phones and other wearables, if you will, to understand the mobility of populations. And, we have not really thought about incorporating those sorts of things into our infrastructure more generally. So that's just one example. I'm sure that there are many others that we could think of when we try to put together healthcare and health for the benefit of the health of the population and individuals. Anything
This is
that- yeah.
Renu. Yeah, I would echo that. Like the concept of real world data is consisting of certainly clinical data, claims, administrative data, but also geospatial data, sensors, omics, PROs, patient-generated data. I think that not the ability to have those types of data in isolation, but the ability to link, curate, quality assure real world data to prepare it for population health is a real disruptor. Like those experiments are just starting to happen, but this concept of integrating multiple data sources and making them research ready and linked, I think is a real disruptor that is starting to emerge.
Great point. That
ask-
has
sorry.
benefit. Yeah, go ahead, Emily, please.
No, I was just going to ask on this conversation, I'm curious about how folks are thinking about the limitations, the demographic limitations of that data. I saw something this morning that was an assessment of where the boom in telehealth happened by county level, and that it was mostly happening in wealthier, whiter communities. So I'm just like, in terms of thinking about things like, the role that apps on iPhones play in terms of, collecting data about people's mobility, or even in telehealth itself, thinking about the ways in which some of that is limited by just income differences in terms of inequity in our country. When we think about sort of the positive nature of that disruption, going back to that question, I'm curious how folks are thinking about its fundamental limitations based on the way in which societal inequity prevents the people who are most hurt by our health system today from getting access to telehealth, from having access to some of these other, or sources of data, or contributing to some of these sources of data by virtue of their inability to afford an iPhone or a data plan that would allow functionality on those iPhones.
Yeah, I guess I'd be interested in what others, how they think of that. My sense is we have to, on the one hand, understand that limitation and figure out how we're going to collect or make available these resources elsewhere. But then to Ranu's point, some of this is sensors and things that can give us information about the context in which people live, and where we put those sensors that might, look for pollutants or things like that is a policy matter, and that can be integrated into what we're calling this potentially real world data added to the infrastructure that can be disruptive. So I think we want to keep the blue sky and think about what other things could be included as a potential part of the infrastructure. Yeah.
Yeah, I mean, I would agree with that, and also echo Emily's thoughts about making sure that you're not building biases into the process moving forward. But I think we need to understand and study what happened with the use of telehealth services and remote technologies, who benefited and how, and then how do we create policies where everyone benefits, I think are very important questions to ask. I would also say, even when we think about data sharing or creating and enabling data through infrastructure, being careful of building bias into that and being proactive with the quick response to COVID, but just generally speaking, we don't engage patients as much as we need to in the creation of the actual tools, the digital tools, and certainly we don't provide as much information as we need to in a transparent manner for patients to understand how that data was leveraged for research purposes and enabling trust in the entire system. So not quite a disruptor, but I think that's certainly a barrier that we need to overcome if we want to bring more people along, particularly when we have reports of breaches or inappropriate uses of data. It can create a vulnerability.
I can't resist commenting on that because I really resonate with the comment, Esther. There's a proliferation right now of patient-led cooperatives that are a response to incomplete participation in healthcare right now. So whether it's for research or healthcare, there are groups like Savvy Co-op that are really very forward-thinking in terms of their approach to co-designing health and healthcare. And I view that as a potential disruptor in the best sense. And now I will go off video and go back to writing things down, but I had to add to that.
Oh, you can stay on anytime, all the time. Well, we may be sort of drifting naturally into the next question, which is what are the challenges and obstacles that are going to get in the way of this progress related to infrastructure? We've already started identifying some of those. So why don't we spend a few more minutes on that one?
I had one, two in mind, and one was what we were just talking about. So I think that's very, very important to pay attention to both who's represented in the data, how the data get used, and to the extent implicit biases that exist today are propagated through algorithms and procedures and so forth. And the other one that concerns me is data access and the extent to which that's equitable. The kind of data I tend to work with is very expensive. I mean, even if it's government data, it's very expensive, and I know that is an access barrier to some researchers. And then there's other data that's proprietary, data collected by, I mean, not to throw any organization under the bus or anything, but Google, Apple, Facebook, so forth, and they are working with it. It's not always, to the extent it's available for others, is not always complete. I just worry about how that's being used and for profit. But it's really our data, right? It's coming from our lives, all of our lives, into proprietary systems and then used and influencing our decisions in healthcare.
Absolutely. And also, our decisions and just our daily health choices, which
Exactly. Yeah. Yeah, it's very powerful, but it's not accessible and equitable.
Right. And on this access to data point, I mean, we've sort of danced around the issues of broadband and having this viewed as a public good or as a utility so that people have access to it. And as we move more into a realm where this data is being collected and analyzed and made available and if there's if there continue to be the massive inequities in broadband access, I think that we're going to see that exacerbated. I would just say recall yesterday's the mention of rural health and the ways in which we need to keep that in our forefront, and this issue of broadband access is front and center there.
At the same time, the potential positive aspects of FHIR and the FHIR standards to pull out of the EHR is something. In fact, I arranged Friday. I have a meeting for Inside Government that I organized about the potential to even enrich the data sets that you'll hopefully be utilizing a couple of years from now. Well, probably more like 7 to 8 of more robust national data on some of these questions. So the positive is the technology is evolving to pull more out. But you're right, it's going to be interesting to see how much data is in the data sets that the government and other insurers. I mean, one of the barriers are that we all work, including in my professional life, in Medicare data, some of which included MA, some of which did not. MA is increasing in the percentage of the older adults. It affects a different population. And, it would be great to have an all-payer data set to do some of this research. And we're not there for a lot of it. Another barrier.
So I had a question that maybe, Esther, it kind of goes to some points you were making earlier around, we've seen some decentralization of clinical trials, which has been helpful, right? And I think something we want to preserve. But I've also become more aware that we have built in barriers to participating in clinical trials just by virtue of the fact that they're often, obligating people to come into a clinical center during business hours. And, you might have to take multiple different pieces of public transportation just to get there. And I wonder, do we start to see that barrier? Is that going? Do you think that'll remain a barrier as we look out 5 years, or are we taking important steps to dismantle those kinds of barriers? And anybody, it's for anybody, but I know, Esther, you brought this up earlier.
And that's a great point, Sarah. I think we saw a response for more decentralization, actually a response to the pandemic and having to work with, a lot of product sponsors having to work with FDA around flexibilities so they can continue their ongoing clinical trials. I think those experiments, which they always had that flexibility, but there's a whole movement and shift towards doing that out of the pandemic. I do think that there are going to be core elements of that will be preserved. So I don't envision fully decentralized trials. I envision some hybrid models as probably best practice going forward. So which pieces of a clinical trial can you go to your local lab? How can you share information, maybe leveraging some technology without having to come in person? Maybe components going forward, but I think that's a fantastic point. That will allow more patients to participate and take trials closer to patients rather than what we currently have within academic medical sites, but also the important role of community-based providers who do not have either reimbursement, staff, resources, research coordinators. The list goes on in terms of the barriers at that level that we can overcome, I think, going forward.
Yeah, I want to bring up something that was in Renew's virtuous cycle, if you will, as a potential barrier. When we think about what it takes to go from implementation to real world data and back again, kind of that positive feedback loop, we've learned that it can be dramatically reduced and made much tighter in COVID. But I think a barrier is that we slip back into the previously accepted timelines for making that continual change. And if we do that, the ability to really build out this infrastructure that accelerates things will be, I think any of the linkages will cause a major obstacle, but that one, I think particularly because it's not until we sort of see things being implemented that we know how we have to adjust them in the real world. And that's what we're trying to get to, is real world change, not small incremental change. All right, it seems like we've hit a lull on this one. We're moving right along. So let's move to.
Sorry, Risa, I didn't mean to interrupt. Can I throw in one more though? I'm totally like trampling over my prerogative, but health literacy, data literacy, and scientific literacy, I think we don't necessarily think of that as traditional infrastructure, but certainly in terms of people's participation in research, people's participation in health and healthcare. I'm curious whether others see that as an infrastructure barrier, or does it belong somewhere else altogether?
I would agree. I think to the extent that it's related to how do we enable more people to engage in health, and not knowing what the I mean, when we talk about even digital technologies, we use so many different words. I mean, I come across digital health and tech. I mean, we have so many phrases, then the actual data science and AI tools and so forth. We're not educating, not just patients, just the general individual, people, consumers around these topics. It's really hard for them to even be part of that. And so you're creating silos even as we're trying to expand and disrupt. So I would agree with that comment.
Yeah, I agree too. And I would, Sarah, kind of link it to what we were saying about communication. Because if you can use communication to address these health literacy issues broadly, I think it has a very positive effect. So I would agree and would offer linking the two. Okay, well, we are at 11:57 and we're marching right through. Sarah's gonna make sure I stay on time. When we think about having measurable positive impact in health and healthcare over the next 5 years, what will it take for infrastructure to have a positive impact on that? So trying to synthesize some of the things that we've said, what do we really think we're going to have to ask of infrastructure if we're going to have measurable change in the next 5 years? So we're not talking about our grandchildren, huh? I know you all are too young to have grandchildren, but I'm projecting.
I have to drop up in a couple minutes, but I would just offer that we need a roadmap of what we can achieve in the short term that will give us wind beneath our behind our backs for maybe things that are harder. So seeing like the telehealth and remote tools actually implemented and the infrastructure needed around that, whether it's broadband or otherwise. But it's in some ways creating a catalyst for action. Once we start to see it, there's sort of a natural inclination that, oh, we can do this. And we move on into the things that are much more difficult. But thanks so much for a wonderful conversation. I hate to have to drop off. Thank you.
I mean, I think from an infrastructure standpoint, certainly it feels like we need a reallocation of resources. Whether you're talking about the government level or in a lot of cases, the systems level, which includes investment, of course, new investments.
And is there a role for advocacy in that as well, Emily?
Yes, for sure. Okay. Yeah.
But, and Risa, I'm old enough to have grandchildren, but I don't have grandchildren. As you know, but old enough. But I always think of what are the levers there. And I think that there are more levers than there were even a couple months ago that people are willing to utilize. So I think there are opportunities. For those who don't know, I'm the CMO of CMS, and we have a lot of levers right now that I'm trying to pull in some of these spaces. So that's, I think the question is, do we want to use those levers to, whether it being quality measurement, but that's more for the healthcare system. But, if we get more towards population health and go in that direction, then it is health rather than healthcare. So the question is, what will the new administration be pushing on? The Liz Fowlers of the world that could force in a particular direction.
From an infrastructure standpoint, just to share, we fund some work at the local and state level where community-based organizations have been successful in working with primarily health plans, but in some cases hospital systems, to resource in new ways social determinants of health, whether that be, investment in housing or nutrition assistance or certain community-based services. So those are, I think, those aren't, I don't think that's the type of, systemic, public health shift that we're talking about. But I do think you're right that in the last year and certainly in the last couple of months, certainly in light of a lot of the conversations that we've been happening with the new Biden administration and Congress, there's more opportunity to pull on new levers, to think about what it looks like to push harder for reallocation of where money goes, which to me is sort of one of the most core issues when it comes to infrastructure in terms of building a system of health versus healthcare.
Right. And Emily, I don't want to put words in your mouth, but I would say reallocation and sustained investment, because a lot of these things have kind of gotten pulled together on the fly,
Right.
and they will, or parts of them will atrophy if it's not sustained. And so that's as critical to it as anything else.
Agreed.
And, the other thing that just listening to the conversation, I'll throw out, we've got a new concept of infrastructure that is much more robust than it was discussed or described 5 years ago even. And yet I don't think that is commonly appreciated the way it needs to be. And so it strikes me that one of the things that PCORI might do is, be relentlessly advocating what this new infrastructure looks like, but also, bye-bye Renew, but also using its work to shore up some of the parts that are weaker, so that there's a definition of infrastructure that becomes as real to ordinary people, to researchers, to policymakers, as we want it to be, so that investment can continue. So, kind of pairing with what Esther said, if we say we've got to have a roadmap, but we've also got to have everyone be clear about what the destination looks like.
I think that's a great point. I mean, as I was listening to you speak, I was thinking, even for local advocates to have an orientation of a shared concept of what health infrastructure means could really help shine a light even for their own clarity on this part of our health infrastructure that everybody agrees, is a part of building communities of health in our country, is significantly under-resourced. Now I feel like I can, as an advocate, stand on much firmer footing when I talk about the need for new investment, the need for sustained investment. So I think that could actually be very powerful when I sort of think about a lot of the health advocates that we work with, to have that shared understanding and really to make, to of course be rooted in, what people say they think of when they think of, where do I go for help? Who helps me keep my family healthy?
Yeah. So we're getting close to the hour, and Sarah, maybe at this point we could just spend a few minutes talking about what we think we've said, so that when we are doing the report out, we all can kind of resonate with it and cheer on. Unless you have anything else you want to add in, Austin. Okay, good. Sarah?
Yeah, well, I missed a few minutes, so I'll see what you said, and then I'll see what I want to add.
Sure. Okay. Let me give you 1 second of technical fumbling here to share the notes I took, which were pretty detailed, and then maybe we can highlight and extract the key points that we want to bring forward.
Okay.
45. Okay. Let's see here. And again, with apologies, I do take very detailed notes, just kind of out of sheer habit. So
No, we love it.
let's see, minimize that. Okay. So let's see. I'll just try to, without reading this back to you, leveraging I think the key point is in Esther's comment about making sure we hold the
Right.
gains that were realized during COVID, and figuring out how to prioritize key topics in clinical trials.
So that we enhance, prioritize, so that we can enhance the learnings and the expansion of that of the network that we developed during COVID.
Mhm.
Great.
And then we talked a bit.
I actually think
Yeah.
these virtual meetings are non-trivial about how we'll be accelerating working together in a virtual world.
Mhm.
Thanks, Lee. Yeah. And then we had a short discussion about communication and dissemination. I think maybe this is at the kernel of what Austin described would be this piece here.
Right. And if we could link to that, your point about health literacy, Sarah, that communication and tying it back to building our muscles and health literacy, and using them as positive feedback loops would be great.
And then, whoops, sorry about that. Then we had Emily's, I believe this was Emily's point about understanding where are the key information sources that people utilize both for social needs and health needs. So how do we continue to amplify other voices to create a more holistic ability to think about health?
Right, and especially community-based organizations.
So I'm actually curious, and I apologize for bringing it up here, but we've learned a lot about vaccine hesitancy and the way information is tracked. Are we going to continue to use that information? Because it's fascinating, the role of the social sciences and behavioral sciences and how we think, at least even in the government right now.
Right. No, I think I like where Sarah's putting that point, Lee. I think it's spot on with the ways our health literacy can, and what we learn about it can be a positive feedback loop. Okay.
I was going to editorialize, I will not. Okay. Okay.
Can I add to Lee's point though? Because I do think, I don't know, Lee, if this is where you were headed, but I personally was very struck by, just in some of the meeting spaces I was in, the different ways in which social scientists and behavioral scientists were trying to help orient people who have, been in the health space or the public health space to the ways in which different sort of learning orientations or just different orientations to sort of the world and society change the way you receive information, so that it's not just about, I didn't get a certain type of information, it's that the way I responded to it, whether it was good information or bad information, is very relevant to effectively other, ways in which either my, I guess the other ways in which my brain sort of has been socialized, the way I've been socialized in the world.
Yeah.
So Yeah, Risa and my colleague Sigal Barced put together a work group that we listened in on of social scientists to tell us like how people would or would not adopt the information about the vaccine. It's a very specific example, but how just putting out, infographics from the CDC doesn't work. And it was really quite interesting to think about, Adam Grant was on it and others. It was quite eye-opening.
Okay.
Smaller it gets, the harder it is for me to.
Right.
Currently, I apologize. Okay. Turning to the disruptors then.
Yes.
So Esther led off with the point about Datavant, and also the work of the CTSAs to stand up the N3C, which is a group I've been studying for my other work with the NAM. So this really kind of resonated for me. And I think there's an important point in here around the ability to ask even better research questions when we have these large networks.
Right. So folks, as I look at these, I wonder whether we can group the UK Learning Recovery Trials and EPIC's COVID-19 databases and expansion at CDC with that first point, that all of the ways in which these data networks have been linked and augmented during COVID and post-COVID offers a real potential for disruption.
Sounds appropriate.
I sort of get that, Risa.
That the ways these have been linked and expanded offers an opportunity for disruption. So we're linking it together, all of these various systems of data that have been pulled together as part of both the discovery process and the clinical process related to COVID, and using them as potential disruptors, not individually, but together.
Great.
And then on the next one, just thinking about some of what the discussion was we have telemedicine boon as a disruptor, but then Renu added in it's telemedicine and real world data. So she was using talking about sensors that we can put in the environment or things that people wear. So it's the combination of the telemedicine, which gives, visual data about what's going on in someone's house, in addition to everything else, the dialogue and whatnot. So it's a combination of these very new methods of getting environmental data, if you will. So so real sources of real world data. You know, I think we want to emphasize that. Good.
And we went on this disruptors and opportunities a bit more.
Right.
So I think this part might be a build on what we were just talking about.
Right.
Rainu made the point about ensuring that the data are ready, that we have these sources, but how do we ensure that they are research ready, I think was one point she would emphasize if she were here.
Yep.
Okay. Oops. Does this, just for my own clarification, the notion of the demographic limitations, is that, I believe that was related to disparities and potentially to rural health, but is there any amplification we want on this second bullet?
I think maybe it would make sense to move that into the obstacles section, since it came up again there.
Good point.
Yeah, I agree.
Thanks, Emily. Okay.
And that one too, who's represented in the data and how it's used in implicit bias. That to me feels like it goes in the obstacles as well.
Yeah, I think I might have, I did cut and paste that in a couple places, so.
Okay.
Belongs, you're right, it belongs in the obstacles.
Right.
Okay.
Right. Good. You type much faster than I can even think, Sarah.
Lots and lots and lots of practice. So Emily, in this second bullet, I think also was pertaining to something you said around, you know, kind of having that dependency. I think that was you, could have been Esther. Dependency on a smartphone. And again, this I know this kind of still revolves around the notion of building biases into our data. So do we want to keep this, or just kind of have it as a side point and maybe not bring it forward in the report out?
Well, I think what she was raising, I mean, it does relate to what we had just you know, decided to view as an obstacle. But I felt like the way she was sort of reframing the point was to basically say, you know, we do have an opportunity to do some research to understand what really happened with the telehealth boom, who benefited from it and how, to inform, policy and other decisions about how to make it, more equitable, how to learn from it. So I do think that that's, it's one way certainly to overcome an obstacle. It also does, I think, present as an opportunity now that there is this boom to better understand it, what drove it, to inform decision-making going forward. I think
that's perfect. That's perfect. Thank you. Okay. So then moving into the obstacles, I've got a couple of slides on this, so hopefully we can kind of boil it down or up as the case may be. So certainly, kind of we'll continue to drive this point home as a critical obstacle. And I think you might have also kind of built on this by talking about the access to the data itself. I believe that was your point. And I think that's a really important aspect of, you know, whose data, who is using the data, and what conclusions are they drawing from it? Can they access the data that, you know, in an equitable manner?
Right. And I think that, yeah, that proprietary data, highlighting that and the implications of the big data giants that are now using their data for health and healthcare related purposes without others having access to it. So what Google and others are doing, that sort of thing. And soon Amazon will have prescription information on all of us.
It almost feels like the hybrid clinical trials model serve as a potential opportunity. So I don't know if we want to take this one and move it back into
That
the.
sounds good.
Yeah, I apparently might have, if you're still, I can't see the screen. I'm not sure if you're still with us, but I apparently stopped mid-sentence because I was transfixed by what you were saying. Sorry.
That, you know, the new technologies are a potential way that will be pulling down more. We'll be able to go beyond claims and be able to pull directly out of EHRs.
Right. So you were talking about the all-payer claims database and the integration with clinical, right? Right.
The integration, right? The mixed clinical plus claims databases that are probably about 5 years away. I'm hoping, that's what I'm hoping to hear Friday.
Okay, that's right. Okay. Great. And that goes with that. Okay, great, thank you. And I probably threw this last bullet in when nobody was looking. Sorry. But I was struck by, when we were putting the topic briefs together, I was struck by the way that the place of care is really getting more and more diffuse, and generationally this will continue, right? So I was wondering if the notion of having even more sites for receiving care, whether it's a retail clinic or a home or a, you know, Amazon's primary care clinic, you know, does this create both an opportunity to better understand the whole person, but
Right.
also more complexity in terms of getting good data?
Well, and for example, we may not know what the exact site of care is.
Exactly.
There may
Right.
not be good linkages.
I was reflecting on this for myself recently because my care has now been fractured across different healthcare systems in the region, and they all have their own patient portals. And some of them can be linked together and some of them can't, and some providers can see into others and some can't. And, you know, it's like we're almost there, you know, all the data is kind of going online and I can engage with the providers and see some data and move it around a little bit, but yet there are these barriers that are frustrating, these silos. And I think that sort of pertains here. You're talking about something broader, but that's a very specific kind of patient, the way the patient sees it. It's
Right.
kind of confusing.
Yeah, and then add in CVS and Walmart and Walgreens. Yeah,
Yeah, I know. I have one health system that's bothering me because they think I haven't gotten like either my flu shot or a certain vaccination booster, and the other health system where I got it, they know I got it, and I can't
Right.
get them to, stop with the alerts already. I did, I
Yeah.
did it.
Okay.
Well, I thought that I was thinking of this, this issue of frustration around the lack of coordination and complexity with respect to the notion of just, patient engagement and excitement and interest in research generally, because I do think that there is just like if people who are in healthcare in some capacity are fatigued on a personal level with, how difficult it is to navigate the system, it does seem to me that it's, one of the barriers to getting people excited about being a part of trying to change it, whether that's in a research capacity or otherwise, is because it just feels so intractable to people.
Right.
And
Oh,
overly
sorry.
complex. And, I do think that is a barrier.
So there's a huge research opportunity in this area. There will be a paper coming out in some months I'm a part of that for the first time, as best we can tell, looks at the administrative burdens on the patient for navigating the health system. So there's a lot of barriers to care, and those administrative burdens are as large and as strong as the financial barriers, which I think for the first time we've been able to kind of quantify that. And I think there's a huge opportunity to better understand those administrative tasks and the extent to which they're barriers. And yes, cost is a barrier, but also all these other things, which are non-monetary based costs, right? They're time costs, they're effort costs, they're cognitive costs. They're huge. They're huge.
Yeah. Right. That's it. I think this last point is really good. I'm glad we had some time to flesh it out. And of course, it creates the flip side of if you could get rid of those, it becomes a great opportunity. I mean, it's like anything else when you see all of your data coming together in an easily so that you can extract the information from it without all those costs. It's it's really powerful. So I think this is an important one. I'm mindful that we're eating into everyone's break, but could we just spend a couple more minutes to look at that last question?
Okay, we had a little bit more, and we already talked about the health literacy and engagement. And then we had the point about the virtuous feedback loop, which I think this is a pretty straightforward one. And I'll wordsmith this before we present it. Okay, so then what else would it take? 5 more minutes, says Ariana.
Yeah.
Let's see. So I think I think the key point from this one was really talking about the roadmap. This is actually just more of a restatement of the question. What are those new opportunities and levers we can pull, both at the local, community level, state level, and national level? What else?
I have to hop to a meeting. I may or may
I
not be back.
Okay, thank you so much, Lee. We're glad you could join us.
Thank you, Lee.
See ya.
Emily?
I was just going to say, I think this last point is mostly just what you have below in the sub-bullet, reallocation and sustained investment is basically the main point.
Okay.
So that can kind of,
Okay. Looks like we have one more slide. This was your point about, I believe it was about.
Yeah. About being sure that everyone understands what the concept looks like and can articulate it so that they know what the roadmap is leading to.
Okay,
And then PCORI can help with that by investing in the weak spots.
Great.
Okay.
Well, I have about, 13 minutes to quickly sort this into presentable form. And then, I know we won't have everybody from the group with us at 12:45, but I'm Risa, either if you want to take the mic and start, or I can start and you can amplify what I missed, we can, whatever you'd prefer.
What's easiest for you, Sarah? I know you've got a lot of other things, and just, I can probably stay until 5:01, and then I'll need to transition to the next thing.
Sure. Well, I feel like maybe I'll start. I'll be quick, and
Okay.
so that you have.
And I'll jump in.
Yeah.
Okay.
Yeah.
Good. Thanks, everyone.
Thank
Thank
you
you.
all
Awesome
so
group.
much. Yeah. Thanks.
Infrastructure rocks.
Yes, it does. Should not leave.
Do we just stay in
I
this,
think-
or do
You might just, you might be able to just turn your video off, because Ariana will bring us back to the main room. So, turn off your video, mute, and take your 12 minutes.
okay.